So Franco, I guess, joined IMO how long ago?
7 months.
7 months ago. So this is very fresh and very new. So we're looking forward to hearing it.
Can I use that one? Thank you. Yeah, sure. Thank you. So good morning, everyone. I'm Franco Pradelli. I just joined Jeffrey's group, and I'm very excited to present this early work I've been working on at IMO that is about exploiting the cost of addiction in anaplastic large cell lymphoma. Oh, okay, perfect. Sorry. So yeah, I know it sounds weird, but I will clarify during my presentation exactly what I mean by that. So we've been hearing a lot about adaptive therapy, and what this paper outlines, as many others, with that when we think about adaptive therapy, especially at Moffitt, we think about the cost of resistance and how it emerged when resistant and sensitive populations compete, right? And so it turns out that when there is a lot of competition, it might be beneficial to deliver a holiday in order that sensitive cell can help the control of the growth of resistant cells. But in this project I just started with our collaborators in Cambridge, the cost of resistance emerges in a different way. So Suzanne Turner's group in Cambridge, they're studying anaplastic large cell lymphoma, ALCL, and they're studying the evolution of resistance to a targeted therapy, that is ALK inhibitors. To do that, they measure the dose response curve to ALK inhibitors there, that as you see has a pretty regular shape. For low concentration of the drug, the cells survive. For high concentration of the drug, the cell don't do well. And then they study the evolution of resistance by having an escalating dose of ALK inhibitors in time and measuring cell count and growth rate during that. And then they measure the dose response curve at the end that, as you can see, has a pretty weird shape. It has a bell shape, indicating that, yes, there is resistance because the cells survive better to a given concentration of the drug, but also there's addiction. So the cell need the drug to survive. And this is fascinating. And of course, oh, sorry, I forgot about this part. This phenomenon seems plastic, so you can revert back to original state if you don't deliver therapy. And also they measure that for many ALK inhibitors. So it seems pretty real and pretty specific to ALK inhibition. And of course, this is not only interesting, but critical for therapy, because addiction can, I would say, enhance the benefit of a holiday. And indeed, in this experiment they made with resistant cells, you can see that when they are untreated or when you deliver a holiday after some time, you see a strong decrease of the cell population. And this led us to our question that is, can we use evolutionary therapy or adaptive therapy to exploit the huge cost of addiction in anaplastic large cell lymphoma? Before doing that, I'll just give you some context. ALCL is a pretty rare tumor, so maybe you're not familiar with that. It's an non-Hodgkin lymphoma originating from uncontrolled proliferation of T cells, and is the most common type of peripheral lymphoma. There are 4 categories. ALK positive is the most aggressive and the most common in children. So usually patients are children, very young children. The standard of care is chemotherapy, but the overall survival after 10 years is 90%, but progression-free survival is around 70%. So there's room for improvement, especially considering the young age of the patients. And ALK inhibitors are being employed as a salvage therapy when chemotherapy failed. And it works at the beginning, but as you can imagine, resistance is observed, and this is why Suzanne is studying that in the first place, right? So I already told you that they observed this incredibly interesting phenomenon, and the reason why they wanted a mathematical collaborator is because, yes, for resistant cell it worked, but it's not exactly clear when you should deliver this holiday when you have a parental population. Because if you do the same experiment with parental cells, well, you get results that are pretty hard to interpret. So this led to our study approach, our mathematical model that is based on the evolution of the dose response curve, that this is what we observe. And so we, as I'm going to present, we start from the initial dose response curve and we try to capture this plastic evolution. So how did we do that? So we started with something that is already present in the literature. We call it the Harris model because it was presented by Harris and collaborators in 2016. And it's a super basic OD model, just 2 compartments. And the reason why we like it is that it's simple, it's biologically interpretable. And if you simulate this model to increasing dose of a therapy, in our case, ALK inhibitors, and you measure the simulated growth rate, what you get is exactly the dose response curve you would expect from a biological experiment. And also, it's pretty easy to calibrate because they're almost a one-to-one mapping to the parameters of the experimental dose response curve and the parameters of the model. And so we could easily calibrate that with the experimental data here. I'm showing that for alectinib. Unfortunately, this model is great, but it doesn't come with like bell-shaped dose response curve. This is like weird. It doesn't allow for that. But we worked a bit on that. We introduced a simple extension of the model. I'm not going to detail into that. We can talk about this later, but basically we're assuming that in time, the growth rate of the unaffected population is going to be more and more unlinear. And this allows to the reproduction of a bell-shaped dose response curve that we could fit with experimental data, as I'm showing here, again, for alectinib. So now we have a unique model that can fit both stages, right? The initial dose response curve and the final dose response curve. So if you think about it, if you want to account for the plastic transformation between the two, what changes are just the parameter. So again, we employed a pretty simplistic approach where we introduce an adaptation variable A that has 2 simple properties. When the drug is on, so when you deliver therapy, it asymptotically goes to 1, simulating like 100% adaptation, whatever it means. And when the therapy is off, it reverts back to 0 to account for this reversibility we observe. And of course, if you deliver an intermittent schedule, it's going to go up and down continuously. And this is a unique variable. And what we do is that every parameter of the model that changes between the beginning and the end will change following this exact A variable, allowing for indeed a plastic transformation between the initial state in blue and the final state in red. These are simulated dose response curve with our model. Another thing I like about this approach is that it doesn't really change how you account for this adaptation. You can make different assumptions. You can ask different questions depending on your data. So you can have different shape of this adaptation variable. You can think about how it goes on and goes off. For now, we saw that the best fit with our data is a simple exponential model. So that goes asymptotically, as I showed, the up and down. And the good thing is that it relies on a single alpha parameter. Heiko will be happy with that. And we could calibrate that with our experimental data that we have. These are, in the black dots you see here, are the experimental growth rate during the escalation dose experiment. And the blue curve you see in the middle in bold is the growth rate simulated using the calibrated alpha parameter. All the other curves are variation between plus and minus 60% of the alpha parameter to account for the variability, natural variability that this parameter might have. So now we have a unique model that can capture a bit what's happening, right? And so we can start like what a good therapy for this tumor could look like based on our in vitro data. And if you think about it, given the expected transition of the dose response curve, it would make like intuitive sense to think, oh, so we give a continuous therapy at the beginning, so we induce some addiction, and then we start introducing holidays to exploit that addiction at the maximum extent we can. And so we tested different therapy that are constructed exactly in this way. So we start with an initial continuous therapy here, and then we start delivering intermittent therapy until the end of the treatment. Most of the simulations are for 300 days. Also, of course, we simulated the cell count for each therapy. You're gonna see curves that are like this one in red. The reason why you see oscillation is that we simulate confluence and receding that would happen in biological practice. So when the cells reach confluence in the plate, the experimental people, they receded. And so we wanted to maintain this pattern in order to compare better the data with the experimental data. The first question we ask is comparing difference which day. So when we start delivering this intermittent holidays, right? And we did many simulations about that. For now, we're not investigating different holiday durations, so we just do 2 days on, 2 days off. And here in this plot, you can see like a glimpse of the result we got. So on the top, you get continuous therapy all the time for 300 days. And as expected, you observe resistance after some time. And so the cells start growing again. And on the bottom, you see intermittent therapy for all the time. And like the immediate thing you can see is that intermittent therapy is always somehow beneficial. Doesn't really matter when you start it. It will lead to a decrease of the cell count, but there is an optimum, and the optimum is actually here. And the optimum is measured by the integral of the cell count. And basically, we found out that it's the place in time where the cell count is minimal. And this is interesting because it suggests a possible tool to use for decision making, because you can wait until, like, you can deliver continuous therapy, you can observe the decrease in the cell count, and as soon you start seeing that it increases again, you start delivering intermittent therapy. That makes a lot of sense, right? Because when you see the growth rate raising again, it means that the cells are adapting. So you want to remove the evolutionary push that is pushing that through that resistance and adaptation and start exploiting the addiction. Of course, there are different ways to deliver intermittent therapies. So we also did a bit. We're still at the beginning. Now, in this big plot, you can see all different combination of holiday and post-treatment for 39 days there. And this is the log of the integral of the cell count. So you see here that for these intermittent therapies that are like about 6 days on, 6 days off, you can see a lot of decrease in the cell count, because you can see almost one order of magnitude improvement in the control of the cell count. So this is interesting, but these are all in vitro data, right? And we were also saying before that if we want to think about an adaptive evolutionary therapy, we really need to have some thing that we can measure in actual patient. And of course, I'm not going to say you that we already have like clinical data, that we already optimize everything LCL, but I think it's interesting and worth mentioning that adaptive intermittent therapy has already been tested in ALCL very recently. It's just a case report, so it's just one patient, is a 2-year-old patient, and intermittent therapy was confirmed to be beneficial, extending the event-free survival of 9 months, and it's like it's 12 months versus the expected 3 months. So for a 2-year-old, you can imagine how much different it is. And the more interesting for us that we are interested in adaptive therapy, the most interesting thing is that they could monitor the disease progression through the expression of NPM1-ALK, that is the mutated protein associated with ALCL. And they measure that from peripheral blood. So it's also pretty not invasive. And this suggests that it might be possible to translate what we got from simulation in actual clinical practice in the future. In conclusion, so if you have to remember something about this talk, I'd really like you to remember is that we present an approach to quantify the evolution of those response in time, and we apply that to ALK-positive LCL treated with ALK inhibitors. And despite being at the beginning of our work, our simulation suggests that it's possible to exploit ALCL addiction to optimize ALK therapy, and that show that ALCL could be a potential new candidate for investigation with that kind of therapies. And with that, I'd like to thank my collaborators, my team, and you for your attention.
Well, there was no chance you sleeping through that one. So any questions? Of course, way at the back there. I mean, come on. Okay, Ari.
Lovely presentation, Franco. So I have one quick question on the case report that you showed within your presentation. So with ALK inhibitors, there tends to be quite a bit of GI toxicity that's associated, so various side effects. So in this particular case report, do they kind of talk about were there lesser or more GI toxicity seen within this particular patient, and kind of your thoughts on that?
Yeah, so thank you for the question. That's also something that is being brought up by our collaborators because our initial simulation were using a higher dose of ALK inhibitors that apparently this is not feasible. In the case report, they don't increase the dose, so they don't observe any more toxicity in the sense that they just deliver the constant dose and then they intermittently go between 0 and that same constant dose. So the overall dose is lower, like way lower, I would say half. So no, they don't observe any worsening in in toxicity. Thank you, Ari.
Okay, right. Well, let's thank Franco again.